Okay. So you've met a lot of cool people at your tables. You've heard some cool ideas. If you want to know more, you know where they're going to be for the rest of the day. Okay. So let's talk about power to the people. So we talked about encouragement and what encouraging environments look like and sound like and feel like. That's what you were discussing, hopefully, at your table. So I just wanted to share some information with you that you probably already know. On the left is a nice little graph there that basically is a breakdown of how people spend their Monday through Friday in the United States in 2012. And if you can't see from far, far back, no problem. I'll let you know that the green down there is working and related activities. That's 8.8 hours. And sleeping came in second at 7.7. Okay? And then there's other stuff like caring for others, which is kind of like work. There's eating and drinking, which is nothing like work. And then there's other like household activities, which is very much like work, and some leisure time as well. So the point is that I want to emphasize for everyone in this room, as if you didn't already know it, is that people spend most of their time awake during the weekday at work. Okay? That's the most time is allocated towards that activity. And what they found about people who come to work is that they're most happy when there's a high degree of flexibility and control over their environment. So flexibility when it comes to scheduling, flexibility when it comes to being able to go to a doctor's appointment, but also a high level of control. So when you think about what high level of control could look like at your site, what I'm talking about is getting everyone involved from the get-go in this journey, on this PCMH journey. Getting everyone involved in QI. So removing all of the silos. So a big mistake I've seen a lot of clinics make is they create these leadership QI teams. They take all their superstars and they put them on one team. Now if that were baseball, what would happen? What happened if you took all the superstars and put them on one team? They win the World Series every year, okay? It'd be a no-brainer. So why do we do it in clinics? Why do we take all the best and brightest, we put them on one team, we put them in a silo, we have them meet 2 hours a week. Great, good job, guys. Everyone here is brilliant, right? Everyone looks at each other and like, you're brilliant, you're brilliant, you're brilliant, okay? And the ideas stay in the room. So it's about spreading the control and the QI to everyone on the team. It's not just siloed on this one leadership or QI team where the ideas stay in the room. Okay. So what also that we know is that happy employees are more engaged. Okay. And engagement could look like creativity. So in places where they encourage a high degree of creativity and being yourself, if I come to work and I feel like I can be myself, I'm happier at work. If I feel like I come to work and I'm a robot and I have no control over anything that I do and I can't be myself, I'm not as happy at work. So thinking about how can you encourage people at your sites to be more creative, to be themselves, to express themselves in a way that's still lending towards the PCMH vision. And what we just talked about was the changing silos, right? From moving away from silos to spreading that across the whole clinic. So how do you get people more engaged? Obviously it's PDSAs, okay? So how many of you at your clinics have encouraged and are now tracking PDSAs? Okay. How many of you are doing PDSAs with leadership teams and QI teams? How many of you are doing them with frontline staff? MAs are doing front desk, are doing PDSAs. That's fantastic. Fantastic work. Keep that up. So I did a site visit to Petaluma Health Center in Northern California, and what I thought was so fabulous was that everyone on that team is encouraged to PDSA. Everyone, you go up to them, and they have a PDSA. You go up to them and ask them, what's your PDSA? And they'll tell you, oh, I'm working on this, or I'm working on that. From frontline to administration to MA to nurse, everyone. And the director there encouraged, like, people come up to me and ask me, should I do this? And I say, yeah, do it. Kathy's amazing there. So if you ever want to do a site visit to a clinic that's high performing, they're an FQHC, they're very large. It's a beautiful place to work, and everyone there is super empowered. By the way, site visits are one of the most inspiring and like soul rejuvenating things you could do. Going to site visits where they're high performing and taking staff from one clinic that's not so high performing and taking them to see it instead of you telling them about it is the best way to roll. Okay, so you can't expect the culture just to change by itself. It's not going to just happen magically one day. And I went to this amazing talk given by George Halverson, who is the former CEO of Kaiser and Health Partners. Have any of you heard him talk or know about him? He's brilliant, right? I mean, he's brilliant. So I took some really good notes and I talked to him, and this is what he told me. So Kaiser took very deliberate steps to change their culture, and you might be surprised at where they started or not. Let's see if you are. The first thing is being very clear about where you want to go, defining it, delineation. Where are we going? How are we getting there? Very clear from the get-go. What we talked about earlier, remember the vision setting? And then you have to say it over and over and over again to everyone. And by saying it over and over again, I don't just mean verbally. I mean, you gotta do a marketing campaign. Marketing, posters, right? Marketing, brochures. I mean, you just say it as many times as you can in as many different ways. Adults learn in different ways. It's not just by talking, right? You see from this presentation what I'm doing. I'm throwing in videos, I'm making you guys talk to each other, I'm giving you some information, right? I'm using adult learning theory to do this. So at your clinics, you have to do the same thing. And you got to teach people how to use adult learning theory. So saying it over and over and over again where you're trying to go. And then you codify it with rules. You got to lay down the rules. What is it that we're going to do here? What is it that we're not going to do here? Establish the rules and then tell people about them and see what they say. And if some of the rules need to be changed, you change the rules. But you still have rules. Now, you might call those ground rules. You might call those protocols. We were talking about ground rules earlier in my table, right? So in even staff meetings, you should have ground rules. What's acceptable, what's not. In your huddles, you should have rules. What's acceptable, what's not. Be very clear about them. And then you have to explain over and over and over, why are we doing this? Human behavior is anchored in the why. We want to know why. Why? Why do I have to do that? Why? Remember when you were like 3 or 4 and your parents would tell you to do something? And the first thing that would come out, why? Why? And those of you who have little children know that you have to answer that question a lot, because I said so. Okay? When you're a child, you can say that to your child. And when you're a child, you hear that, you're like, ah. But adults don't want to hear because I said so. So you have to create the why. And then you have to enforce it. And you have to enforce it in a way that doesn't make you the police, but that the enforcement becomes kind of natural and ingrained in the culture. And people start enforcing it within themselves and with each other. But it's not in a punitive way. Again, we're not trying to punish people, but we're trying to stick to the rules and to the vision of where we're going. And if you don't enforce it, now think about, you might think, oh, I don't want to enforce it and be the cop. But think about what happens when you don't enforce that behavior. Think about that 1 or 2, maybe 3 people at the clinic who don't follow the rules. How does that make everyone else feel? How does it make people feel? Oh yeah, super resentful. I'm doing it and they're not. Nobody cares. So why should I be doing this? And after a while you get cynical, and after a while you're just like, I'm not going to do it either. Right? So it might seem like you're policing, but really what you're trying to do is help the people who actually want to do this vision. The people that are on board and want to do it, you're trying to help them. And those 1 or 2 bad apples, they may conform, but if you remember the innovations chart, there are some people at the very end of that spectrum that we call the laggards. And the laggards may never conform. And what happens? What happens to those laggards? They leave. And that's okay. That's okay. Absolutely okay. Go open up your own private practice. Absolutely fine, right? You don't want those bad apples. And I know that makes you kind of cringe because you're like, oh my God, what are we going to do with our patients? Okay? But think about the culture you're trying to create. Think about this long-term, 10-year culture change. You'll figure out what to do with their patients. It's better to bring new people on board that are in line with that vision and culture when you're hiring them than to try to deal with those laggards that are poisoning the well. Okay? Number 6, continued reinforcement and enforcing over and over and over again. So we're sticking to the why, we're sticking to the culture. And then you have to celebrate. You have to party. You have to find those people that are doing it well and support them. Put them in the spotlight. But remember, it's not just putting them in the spotlight, because you don't want them to seem like it's totally undoable. You got to put them in the spotlight and make it seem doable. And make it seem like, hey, I want to be that person. I want to be in the spotlight too. How do I do it? I want to get there. But you have to celebrate. And you have to celebrate in a way that tells a story. You have to have a story to share. Because remember, this is how, for years and years and years, before we had paper, before we had iPhones, before we had laptops, we told stories. So having a story to share and tell and feel good about it, like, yeah, this is what we do at our clinic. At our clinic, we have team-based care. At our clinic, we do panel management. We do it well. Telling those stories and sharing that makes people feel good. And then you find those people and you put them in the spotlight. We talked about that a little bit when we talked about celebration, iconization, when we find those exemplars and make it easy to follow. And then you have to do what you preach. Practice, practice, practice what you preach. If you are practice coaches and you walk into clinics talking about change, everyone here is going to change. You got to practice changing your own life. If you walk into a clinic and talk about well-being, or you talk about employee happiness or employee joy, and you're miserable at work, how do you think that comes across? There's an energy there. People can read that energy. So if you're a miserable employee, you hate your job, and you're walking into clinics talking about joy at work, you're in the wrong field, right? If you're walking into clinics talking about change, and you find it really difficult to change, you have to do some work. You gotta do some work, because you gotta practice what you preach. And then finally, things get stale. Things get boring and old, so you gotta find a way to jazz it up, renew the energy, and get people going again. And then finally, the culture changes, and it just becomes, this is how we do things here, right? You don't set the culture from the beginning, right? It's not like, number 1, culture change. That's not what you saw happen. There's a process you have to go through. And sometimes you gotta go back around and do the process again. That's okay. So part of that process, talking about processes, that people need to go through to change to become higher performing, this is the building blocks of high performing primary care. These are the building blocks that we came up with and put together in a particular order based on our site visits to high-performing practices across the country and our own experience doing practice coaching and talking to leaders, and because Tom Bodenheimer is brilliant. And so with this model, what we help clinics do is figure out the stepwise approach to becoming PCMH. This, for us, is the why. So when we're talking about how do you get people engaged? How do you get them to understand the vision when it's more than just checking off boxes, right? Because PCMH is more than checking off boxes. It's really about changing the way we deliver care because we need to. This is the why that we use, but it's also the roadmap. But more importantly, what this should show you is that when you're doing practice transformation in your clinics, you need a plan. A big plan, an overarching plan. And you need the why, and you need to get everyone in the clinic, medical assistant, front desk, administrator, I don't care who it is, to know the why and the roadmap. That's what we do in our clinics. So what I'm going to focus on is one of the foundational blocks. So the team-based care is number 4, which means that there's 3 blocks before that you have to do before you can even start thinking about team-based care. And maybe some of you have already done that. So number 1 is engaged leadership. Number 2 is data-driven improvement, which is really knowing your data, knowing how to use it, getting everyone at the clinic using it so that your MAs know the data, that your front desk knows the data. And then there's empanelment, which is matching patients to a team, but making sure the numbers are appropriate and making sure you're cleaning those panels so that patients have good access. Then we jump to team-based care, which is something you indicated that you're having issues with. So when we talk about team-based care, this is what we're talking about. There's 2 components. One is team structure, and one is team culture. So team structure for us is stable teamlets. That's a pairing of one clinician to either 1, 2, or 3 non-clinician personnel that they work together with all the time, every day. And then there's the whole part of the team culture. And I know people have been talking about co-location, which is teams sitting next to each other. We're going to talk more about share the care a little bit later on. There's standing orders. There's workflows, which I don't know if people love making workflows. That's sarcastic. There's a lot of training and skills check and cross-training. There's the ground rules that we talked about. And then there's all that communication that needs to happen on the team between the huddles and the meetings and the constant interaction. So we're going to talk about huddles and stable teamlets. Here we go. So our first thing. OK, so the case that I want to talk about is something I personally just experienced a week ago. I'm practice coaching a new clinic. And I showed up there and I observed a huddle. So I asked them, how did you guys start your huddle? So what happened? Tell me what happened. So here's what happened. The first thing that happened was the clinic QI director attended this PCMH class, and she learned about huddles, and she got really excited. She's like, yeah, huddles, I love huddles. And she wanted to do huddles at the practice, but she realized that she didn't have any support. So she's like, what am I going to do? What am I going to do? I'm going to create a PCMH team. And some of those people volunteered. They're like, yeah, I want to do this. She went back and told them. And then some of them got voluntold. Basically, there were people that she was supervising, and she said, now you're on the PCMH team. So think about what's going on so far, OK? Be critical now. We're being critical. So finally, the PCMH team meets, and they agree on the huddles. They're like, yeah, huddles are great. We love huddles. So the next step was, at the next staff and provider meeting, the huddles are introduced. So the PCMH team gets up there and says, next Monday, we're going to start huddling at 8:30. That's it. By the way, I asked her. I was like, is that all? And she's like, yep, that's all we did. And then for the rest of the week, the PCMH team reminded people, hey, don't forget, next Monday, we're huddling, 8:30. Be there, OK? 8:30? You're going to be there, right? You're going to be there? We're huddling next Monday, 8:30. Everyone? OK, good. All right. So that next Monday, the clinic started huddling. So first it was like a clinic-wide huddle. They met in this middle of this room, and basically the agenda for that huddle was to talk about the teamlets huddling. So I can't make it up, guys. I cannot make it up. So at that clinic-wide huddle, they received a huddle sheet that had suggested questions to ask and discuss during your huddle. And then the QI director said, OK. Okay, go huddle now. So I show up a week later, 1 week after that Monday. And I was like, okay, let's see the huddle. So first, the clinic-wide huddle was improved. There was an agenda on the board, and there was some standing agenda items, and they talked about like the flow, they talked about people that weren't there. It was a good clinic-wide huddle, and most people were there. A couple of the clinicians were missing. They showed up a little bit later, and then we broke up into the teamlet huddles, and I was really excited to go see them. It turns out only 2 of the teamlets huddled. The other teamlets, I went up to them and I asked them, so did you huddle? And they said, uh-huh. It was impossible for them to huddle in that time. Impossible. Like, there's no way they could have done it. So basically, 2 of the teamlets huddled, and 2 of them did not, 50-50, right? And the 2 teamlets that didn't huddle, because there's only 4 teamlets there, those clinicians were kind of old-fashioned. They were the people that were the later adopters and maybe even laggards. I'm not sure yet because I'm just getting to know the clinic. So I had a discussion with the QI director, and I was like, let's talk about adult learning theory. Let's talk about how do you roll things out somewhere when no one's doing it, because this probably isn't the best way. Do you agree? You see a lot of gaps here? A lot of things that you would have done, like, ooh, I would not have done it that way. So I'm going to tell you what I think should have happened, and you may or may not agree. There may be things you think should be added in or taken out. So first thing I think needs to happen is the QI team, whoever it is that wants, is doing the research. Remember, I don't really believe in QI teams, but most places have them, so that's what we're going with. So somebody's doing research. What are huddles? What are they? How do they fit into this big picture of the why? Why do we even need to do huddles? Why? And who's doing them already? And what are the best practices? Where are they huddling really well already? Because I don't want to reinvent the wheel. If it's already working somewhere, let's start there and see what happens. And then you gather the resources to speak to the whole clinic. You know you have to gather proof. You have to have the proof. So when you show up to the whole team meeting, you have something to show them. So you show up at that meeting. It's clinic-wide. That means it's not just the staff. It's not just the clinicians. And I know this is what happens, is that the teams are meeting in silos. Clinicians are meeting, staff is meeting, but nobody's meeting together. Happens a lot, okay? I'm talking about a clinic-wide meeting where you present and you share the information. And you don't say, hey, guess what, next week we're huddling. You say, you know what, we think this is a great tool. And it has helped these clinics do X, Y, Z. This is what it actually does. What do you think? 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 You actually want to hear people's answers. You can't be afraid of hearing what people have to say. What do you think? And then, if we agree, what do we need to do this? What is it that we actually need? How can I help you make this happen? Then you share more information. You show videos. Okay, I'm going to show you a huddle video today. You share huddle templates. You share where they're already doing it really well, right? You're setting up your case here. And then you have to create workflows. I know you don't want to do that, but you have to create the workflows. When are we going to fit huddling in? What do you need to prepare for the huddle? Who's going to do that preparation? And then you have to put it into the template. You can't just expect people to show up and do something if it's not gridded. You really can't. You got to give them it's not even fair. There has to be protected time. And then you have to do some training, because maybe the MA doesn't know how to scrub. Maybe the nurse doesn't know how to scrub. So there needs to be some training, and then you evaluate. Do they learn how to do it? If they're not, you give them more training. It's not a punishment. And then you set a start date. It's kind of like smoking cessation, where you have to set a quit date. Very similar. You have to set a start date. When are we going to actually roll this out at the clinic? So then, once you start doing that, it's time to PDSA. Of course, that's a natural next step, okay? You test it out for a few days. You talk to people. You go up to them. How's it going? How's it going? How's it going? And then you improve the process. You share some new knowledge. You PDSA some more. And then, remember, you find the exemplar, the icon. And you have that person get up in front of the whole clinic and model it. Show us how you huddle. Show everyone here how you huddle. You show them. And then you have to track how it's going. You got to collect the data, and then you display the data for everyone to see. How often are people huddling? What time do the huddles start and end? Tracking it and showing it and making it not anonymous, right? Put people's names on it. It's totally fine. They'll get over it. And then you got to talk about it and share stories. Are the huddles going well for you? Are they going well for you? Oh, it's successful. How have you been huddling? How has it helped you, right? And you'll know if you've done huddling, in the beginning, people are very resistant to it. I don't have time for that. What am I going to talk about? I got to show up early? But then after they do it, it's actually really beneficial for the flow of the day, and those stories come out, and you have to share them. So write them down and put them on the wall, right? Have a quote wall. Dr. So-and-so says, huddles have helped me in this way. Share that. And then enforce it. If people are not huddling, it is now your new standard. You must enforce it. And you have to reward it. Maybe people that huddle on time every single day for a week get a little prize. You know, some coffee, I don't know, something. And then you know when you're there, when you don't have to test anymore, when people just know huddles happen here. People are huddling at the right time, everyone's doing it, and that's going to take a little bit of time to get there. It's fine. So I'm going to show you a video that you could use, or maybe you've already seen, to teach people how to huddle.
About 1 year ago at Campman Family Medicine, we started a new project to improve our streamlining of our patient flow and efficiency in the office. We call it a huddle. Now, a huddle consists of several different providers, namely the physician, typically his nurse, a medical assistant or someone from the front office, and then possibly the office manager if that's available. Important components to a successful huddle are that it be kept very short, usually no more than 5 minutes. We always try to meet in the same location so everyone knows where to huddle. And it's important to bring some type of a communication instrument, just simply as like a notepad. And then also the day's schedule, which usually we printed up the night before, is also very helpful. During the huddle, we discuss all kinds of things that can help these days go faster or go more smoothly, and other things that can get in the way. An example of these would be if a physical is scheduled back-to-back with another physical, or lots of well-child visits together where immunizations may need to be given. Some patients have special needs, such as they need a wheelchair. Certain procedures require certain equipment that may be used by other providers, so it's good to coordinate that. There may be certain patients that have a habit of showing up late or not showing up at all. Some people may need a translator. Some people always ask about their spouse or another family member, so having the chart ready for those other people, just anticipating that, can also help it to work more smoothly. So the small amount of time that's put into a huddle can really pay off dividends during the day, helping the day move much more smoothly, and also improve communication with the front office and the back office.
Today we are going to show you a couple different huddle scenarios. You will notice that the first huddle goes very smoothly.
I see Shelby Tardy is on my schedule at 11 o'clock and has a 10-minute appointment. She's usually late and usually has many problems. So I wonder if we can block the next open appointment and I can catch up then.
Yeah, all right. You have 4 openings this afternoon. Johanni's schedule is pretty much wide open, so after your schedule is full, do you want me to ask the schedulers to give everything else to her?
That would be good, thanks.
Dr. Begro and Bruins both have procedures at 8:30, but they only blocked the procedure room for Dr. Begro this morning. So I don't know if that's going to be a problem or not.
Do you both need the Elman unit?
You know, I don't need it for my procedure today, so I'm happy to do my procedure in another room. But today I got to get out by 5, so if there's a way we can have my last patient be no later than 4:20, that'd be great.
Yeah, absolutely.
And Dr. Begro, you have 2 well-childs back-to-back at 3:30 today, and their mom usually has questions about herself when she brings in the kids.
Yeah, you're right. Let's make sure we have her chart available in case I need it.
Abby, any comments from the patient experience log?
Yeah, we have 4 comments today. Thanks for getting me in within 2 hours after I called. That was patient Dr. Bruins. Great service as always. You got me in the same day I called. That was patient Dr. Begro. I was brought back within 5 minutes of checking in, but I did wait 25 minutes in the room with nothing to read. That was patient Dr. Bruins. And why don't you accept American Express? That was with Dr. Walsh.
Okay, I'll check on that American Express. I'll put that in the parking lot, and I will check on it. And then Mandy, would you please remember to ask patients if they want to read something in the room? And also, if you're going to bring someone back early to do the vitals and you know they're going to have a wait, if you would just tell them about how long it would be. If it's going to be a while, you might want to send them back out to the waiting room, you know, for them to be more comfortable.
Yeah, I noticed my magazines are getting low back here and kind of old, so I'll remember to bring those back and also say that to the patients when they come back.
Great, thank you. I think we're done. Thanks, everyone.
Thank you. Now we would like to show you what happens when people do not show up on time for the huddle.
Good morning, everyone. Dr. Bowen's here yet?
I haven't seen him yet.
Okay, we'll start without him again.
Actually, Dr. Bowens and I did look at his schedule last night, and it looks okay, but if he's not here in the next few minutes, we may need to block his 9 o'clock urgent visit slot, or else he'll be behind by then.
Well, Johanni's schedule is wide open, so we should be okay there. Also, we need to go to the basement for Tom No-See-Often's chart. He hasn't been seen in 4 years. Did you want us to block some extra time?
Yes, he'll actually be like a new patient.
Any comments from the patient experience log?
Yeah. One of Dr. Bowen's patients stated that he felt rushed and didn't get enough time with the doctor. Also, there was a comment from a patient yesterday that the gown was ripped. Can you put it on the parking lot?
I will put that on the parking lot, and I've had a couple of other complaints, so I'll actually call the linen company.
Hello, everyone. Morning.
Hi, Dr. Bowens. Well, we're done with the huddle, as usual.
Well, you know, I've been meaning to actually bring this up with you. Could I have a word with you?
Sure.
We've had very few things of substance to bring up during these huddles, and I'm not sure that they're really useful.
Dr. Bowens, you may not find the huddles useful, but the rest of us do. We just blocked your 9 o'clock urgent visit slot because you were late, and Jenny also found that we have a patient that hasn't been seen in 4 years and asked if we needed extra time blocked so you don't get further behind. I've noticed that it's really hard for us to do these huddles when no one's showing up. There's been a few times when I've come and no one's been here for the huddles.
Okay, thank you, Valencia. I do want to say, though, actually, Dr. Bowens and Valencia, you've both been late for the huddles quite often. I think what happens is that the MOS comes here, there's no doctor, no CSA, and they are thinking if you don't think it's important, then it's not important. So then they don't show up the next time. I want to continue with the huddles. Go to Dr. Bruins and Dr. Begro's huddles. They're very productive, and they're doing very well. They're always on time. So we're going to continue, and I'd like you guys to be on time.
Okay, we'll give it a try.
Okay.
Thanks, everyone.
So this is a tool you could use, right? But also it's a good example to show you how team number 2 needs some help with conflict management, as well as some communication skills, as well as understanding the value of huddles and making sure that the huddle is valuable to them. And right now, that's probably not the case. How many of you are working with clinics that are already huddling every morning, no problem? This is a game changer. Huddles are a game changer. If it's something that you can start working on, I would suggest you do it very quickly. Here's like an example of a huddle checklist, and it's basically going over what kinds of things that you would need to talk about in a huddle, like setup of a room, the preparation, scrubbing the chart, checking in with team members in the beginning of the huddle, how is everyone doing, who's not okay, any issues for the day. And this is something we can share. I just wanted to show you as an example, but we have lots of these kinds of huddle scrub sheets. Okay, I was told I can go over, Mindy. So we're going to talk about team-based care really quickly, building effective teams. So I just want to share with you this quote. It's naive to bring together a highly diverse group of people and expect that by calling them a team, they will in fact behave as a team. It is ironic indeed to realize that a football team spends 40 hours a week practicing teamwork for the 2 hours on Sunday afternoon when their teamwork really counts. Teams and organizations seldom spend 2 hours per year practicing when their ability to function as a team counts 40 hours per week. Isn't that ironic? Okay? So if you don't already have opportunities for your teamlets and teams to meet more regularly because they're just seeing patient after patient after patient after patient, don't be surprised if you don't see change happening quickly. They have to have that opportunity to work together and meet together to do QI. Okay, so how do teams happen? I want you to recall what I told you about huddles earlier, about what went well at that clinic and what didn't go so well. And just think that huddles are like a tiny piece of teamwork that happened for 5 to 10 minutes a day. Okay, so basically what I'm saying is that effective teams are going to take more time, more resources, more effort on your part and the clinic's part, basically more of everything. And I'm not saying that to totally make you feel overwhelmed. It's just reality. It's going to take a lot of time and more work. So what do we know about teams in the field? Okay, so let's learn about the Lakers. Who knows about Kobe and Shaq? Okay, Kobe, great. Was he great? He was great. One of the greatest players of all time, right? How about Shaq? Also great, right? Fantastic. What happened when you put them together?
They didn't team.
They hated each other. Okay, they didn't work well together. So when you're creating teamlets, you have to take personalities into account. You can have 2 superstars, but if they don't get along well with each other, it's going to be disastrous. You also have to consider schedules. Making teamlets takes a long time because you have to look at the schedule. It's a lot of work. You look at the schedule, who matches up. Now you have to think about personalities because you don't want Kobe and Shaq on the same team. And then you have to have a lot of conversations. You have to talk to people individually. You have to talk to people as a group. Remember, talk about it, talk about it, talk about it. And one of the clinics that I work in, they sign prenups. The teamlet comes together with the medical director, and they sign a prenuptial agreement based on their own terms. I'm not even kidding. Okay. So then you have to set a start date. Remember from before? Set a start date. Have more conversations. And then you need some exemplars. You need some teams that are doing it well, and you need them to coach other teams. You know, sometimes clinicians want to learn from other clinicians. Nurses want to learn from other nurses. Medical assistants want to learn from other medical assistants. That's fine. Encourage that. Encourage people to check in with their own teams in terms of like licensing. Doctors want to talk to doctors? Let it happen. And then you have to enforce it, right? So if people are not working with their teammates, you gotta do something about it. You reward them, and then you also have to collect the data and display it, just like with the huddles. And then you have to give them the protected time to meet. Once a week at least, for an hour at least, because you want all of those teamlets doing PDSAs. Remember, this is how we're empowering people. Everyone on the team should be doing a PDSA. And the only way you're going to get that to happen is by giving them protected time. So a very quick activity. This is called Share the Care. This is a tool that I use. It opens up the conversation about how do you actually take away things when people are used to doing them. So for instance, I'm a nurse and I always do this. Or I'm the medical assistant and I always do this. But more often than not, it's I'm the clinician and I always do all of these things. So how do you then take those tasks and redistribute them in a way that uses your people to the top of their license and it makes the most sense? Okay? It's called Share the Care. Basically, on the left-hand column, it's all the common tasks that happen at the clinic. Those tasks can be modified. They're all your own tasks. You know your clinics better than I do. And then you create these columns, and you have people vote. You can actually use this in the clinic. You have people tally where they think they fall. So, for instance, mammograms. You have everyone fill out their own sheet, and they say who's doing the ordering of the mammograms, who's doing the ordering of the immunizations, who's actually giving the immunizations, right? And what you find in most places is that that clinician column is usually filled, where there's poor team-based care, right? And then you have to talk about how do you change that. So we're going to do that quickly, a mini version of Share the Care. What I want you to do is list a few. It doesn't have to be 5. It could be 2 or 3. Common tasks at your clinic. Things that are commonly done at your clinic. And let's just say for this activity, they're commonly done by the clinician, but they could be done by somebody else. Common tasks, 2, 3, that are done by clinicians now that could be done by somebody else. What are they? And then after you wrote down those 2 or 3 things that clinicians are doing now that could be done by somebody else, who could do them? For instance, if you did a training, or you did standing orders, or you reshuffled the teams around, who could do these common tasks? How could you leverage the team you have now? And then the last part of that activity that we do in clinics, so I'm providing this to you so you could actually take it back to your clinics and do it, is what do you need to make that transition? Do we need training? Do we need standing orders? Do we need buy-in? Do we need to educate patients about it? So this is how you open up the door to Share the Care. You have to get people talking, and this visual, this activity on this sheet, and I think Mindy can share this as well. So we have it in our toolkit, right, Mindy? Right. This activity really helps people to start thinking, wow, we're not using our team effectively. And you can be strategic. You pick the left-hand column to show that you're not using the team effectively. So you modify those tasks. To show, for instance, the nurse is doing everything, let's say. Or the clinician's doing everything. Or the MA is doing everything. And it could be done by somebody else. So I just want to hear if you did this activity really quickly. What did it take to make the transition happen? What kinds of things did you write down that it's going to take? Buy-in. Always buy-in, right? Got to start with the buy-in. Training. And I urge you not to do the training first. So I know a lot of places start with training and think that by training you're going to change the culture. That does not work. I've done lots of trainings in lots of places around health coaching, for instance, and they've never used it. So training doesn't make things happen. Right. Getting clinicians okay with letting go control, which means there has to be a system in place that they can trust. So they know that other team members have been trained, they've been evaluated, they have the protected time, there's the workflow, right? They have to know the systems are in place. And remember, those that don't agree, eventually, what happens to them? They leave. We're okay with that. We're okay with that. We don't ever want to leave. But the, one or two people that are never going to change, no matter what you do, that's fine. Okay? So maybe you wrote down some of these things: conversations and buy-in, some training, standing orders, workflow adjustments, PDSAing, lots of PDSAing, people, data, and then more of the above. Okay, so now I'm open for business. Your thoughts, your questions, and it doesn't have to be for me. Maybe it's an expert in the room, like Mindy, other people here. Yeah. So it's basically coming together to agree on ground rules. So you bring two people together in a room and you say, what do you need to work on a team, and what do you need to work on the team, and you create ground rules together, and then they sign them. So what time are we going to show up? Are we going to take, in some places they actually take vacation together, like the MA and the clinician will take vacations at the same time, and they agree to that. Mm-hmm. You want people to self-select in the beginning, because I want to believe in it, right? If I believe in something that I'm testing, I'm going to do it, and I'm going to love it. But if I don't believe it and you have to tell me to do it, it's a different story. Eventually, we're going to tell people to do it, because that's just the way it rolls. So at Health Partners, I've asked them in Minnesota, I said, how do you, because they get lots of things to happen across a huge system. Like, how do you get things to happen here? And they say we test it at 1 or 2 or 3 clinics for a month or 2. As soon as we find out that it's going well, we stop the testing phase and we roll out. And we say, this is the way we do things now. We roll it out across the clinics, we train all of the clinics, and then we start coaching them. But it happens because we say so. We say it's going to happen, and then we provide the resources to the teams to make it happen. But that's their culture, right? They didn't get there overnight.
There's a lot of, going back to the culture question, I think it's really important that we can kind of really needing to educate the patients on culture, because I think there is a culture shift that needs to happen on the patient end. And I think that's going to drive a lot of change for team-based care, and really is going to be a good proponent to drive change for culture change. If that's an expected thing that the patients are saying, if I can't get into my doctor, I want someone else on my care team.
Yeah.
And I think so. I wanted to add that in, because I think that's really huge. Is we need to, as patients, we need to be expectant to take care of be the primary folks in our own health. We're the most important people, and then I think that is a great way to kind of drive the why we need to change the culture in our practice, including team-based care.
Jillian, that's a great point. I'm going to blow your mind a little bit. Take it a step further. Ready? I'm going to one-up you. So annoying, I know. So in Humboldt County, what they've done as a one-up to not only putting patients on advisory councils, but really, truly delivering patient-centered care, is they are training patients as quality improvement coaches. You love that? You're doing it too, right? I mean, it's brilliant. It's like, wait a second, why aren't we having patients involved in all of the changes that are happening? And then when you talk about culture shift, they're your ambassadors, right? They're the ones that go into the clinic and talk to the other patients about the changes that are happening. And they believe it, and they know it, and they're the ones that have helped design it. It's beautiful. And that curriculum is available online through Robert Wood Johnson Foundation website. So it depends on what you think a high-functioning teamlet is supposed to look like. I can tell you in San Francisco, we've done one set of measurements, which is around high-functioning teams working closely together, so stable teamlets, and team culture. And we measure that on a scale that we've created. It also includes the Maslow burnout inventory, but other kinds of measures as well. And what we're looking for is to see, are clinicians less burnt out and less cynical when they're working in a tight team and that team has a high sense of team culture? And what we found out is yes. So for one of the things that we think is a success is when clinicians have less burnout and less cynicism, right? But other things also, you could look at like health outcomes, right? You're looking at A1Cs, you're looking at panel management. You're also looking at staff satisfaction, because a lot of the turnover that happens in the clinics are with the medical assistants or the front desk, and that costs a lot of money and it kind of ruins your culture, and then you got to retrain people. So you basically want the people, what success looks like to me is you want the people in your clinic to stay at your clinic and transform and want to work there and buy into the mission. And I don't know if, there's a lot of different inventories you can use to measure that, but one of the best ways is to go and ask people. Yeah.
You talked a bit about how you are not a huge fan of just QI leadership teams, and it's probably a large conversation, but
Yeah.
I'm just curious.
I'm not a big fan of siloing change and superstars on one team. So unless there's a good way for that to spread, where everyone feels like I'm involved in this clinic change and my voice is heard and it's valuable and I can actually make a difference here, then siloing that into one part, like a compartment, you're really not helping the clinic make this big culture change. You know what I mean?
Versus like a pilot team.
Yeah. A pilot team is different. If you like pilot something and then you spread it, that's different. Yeah.
Follow up to this conversation. For me, I see what you're saying, especially if there's somebody whose role it is to project manage quality improvement. But in practice I work with, there isn't like a QI coordinator a lot of the time, and so that's the function of the QI team. Is the first round of kind of brainstorming ideas, and then doing the project management of, what is our strategy? What is, taking the vision from the larger group and saying, okay, how do we turn this into bite-sized pieces and move forward with that? So it's in that function of the QI team.
Yeah, that's great.
And then I wanted to follow up to the example with the huddles. Another thing that I find helpful is like always going to the smallest possible level. So instead of rolling out huddles across the whole practice, the provider's role is open to change and is going to give it a good effort. And then you have data to use when you're going to the other ones to say, oh, see, they had a good experience. And here's what we measured, and here's how we used it. You know what I mean?
Yes.
But that's just another observation. And then lastly, it pains me deeply that Shaq and Kobe won 3 championships.
I know.
together
I
as a
know.
Blazer fan.
I know. I know. They did win championships. They did win. Just to go back to your point about huddles, the only caveat I have around that is if you pick the superstar, totally enthusiastic team to huddle and then try to make them the poster child of your huddles, you might get other people looking at that poster like, yeah, of course, oh yeah. I mean, they're teacher's pet. They always do those things. They're, whatever, we're not gonna follow them. That's the danger. So you wanna make those people followable, right? If they're gonna be leaders, people want to follow them. So I would just,
Yeah, I'm in more in the sense of like sometimes in establishing workflows, you might like deal breakers happen. Like,
Absolutely.
you might in one team before you roll it out. Then,
Yeah, true. Okay, so here's what's gonna happen. Mindy's telling me what to do. When you're done, 15-minute break. We're gonna get a 15-minute break, and then we're gonna do case studies, all here together in the same room, right? Okay, so thank you so much. 15 minutes for you. Have fun.